Hello and good evening to everyone. I'm Dr. Philip Macmillan. I have been interviewing experts from across the world since 2020 about COVID. I was the first to interview Gert. I was the first to interview Malone. I was the first to do a video interview with Shankara Chetty and many along the lines. And throughout that time, I have learned so much. But one of the favorite people that I speak to is Dr. Chetty, as well as Gert, and I'll hopefully talk with Gert again soon. But listen, I need you to understand something. Dr. Chetty is very unique. I have followed him in the sense that we had worked together as president and vice president of an organization for a while. So I've got a close insight into him and his thinking. And I think history is going to come back to the fact that this guy came up with some genius concepts in COVID. To the extent that before I did this presentation, I was doing a review of the strategies in COVID. And I used AI, used the Great Barrington Declaration, looked at lockdowns, everything, when vaccines were coming, if we had only concentrated on the high risk, did all kinds of angles. And when I put in the Chetty protocol of steroids and antihistamines, it came out that that would have been by far the best global outcome. Incredible. And guess what? We are going to talk to him again, not just about what happened in the past, but as usual, we're going forward in the future. Just a reminder before we start is that we are talking about the fact that COVID is still circulating. What are the implications? And in that process, I am then also talking about predicting the viral storm. And this is because Gert had talked about a HIVICRON, an evasive Omicron variant. And my question is, what is the clinical presentation? So this is what I'll be talking about soon. If you're interested, click in the description below and join us for that. Remember to like, make a comment, and subscribe if you haven't already. That's how we keep this kind of information at the forefront. So without further ado, let's bring in Dr. Chetty. Shankara, wonderful to have you again. As usual, I think that we need you to do a quick introduction of yourself so that everybody knows who you are.
Hi, everyone. Hi, Philip. I'm Dr. Shankara Chetty. I'm a natural life science biologist and general medical practitioner in Port Edward, South Africa, surrounded by a diverse mix of patients, all races and socioeconomic groups. I was a frontline doctor during COVID and took the time and the science background to notice some patterns, figured out an early treatment strategy from what I was seeing, got very good, quick results, and so ended up training doctors around the world and uh, became infamous for standing up against the vaccines and I think more in the understanding of what was happening globally. So I'm still integrally involved in treating COVID cases, long COVID, and vaccine injuries through the pathophysiologic understanding that I've gained.
Excellent. And Shankara, I think it's important to say that they had taken you to court and they've delayed this again for like another year because you were too ready, it seems. But I
Yeah.
want to highlight an important point. And just if you're an audience member, listen carefully to this question. Dr. Shetty has had zero deaths from COVID patients. Now, think about this. I recently mentioned this to another doctor and I said, "Do you believe it?" And he goes, "No, it's not possible." And so here is how you know that what he did was true, because when they went for the court case, when they're going after you, they have not included the fact that you have falsified any information about the deaths.
Not at all, Philip. And I've had Professorios from Rio Grande look at my data. Okay, I sent him very typical data sets where I had blood results, and his analysis of it showed that it would have had a great impact. I think he proved that looking at the South African death rate at that particular times in point where we looked at data, we could have reduced the mortality and morbidity by over 25 times by just instituting the simple protocol of treating it early.
And I think that a lot of people don't understand the science. And I think that's probably why they are struggling so much. And they can't believe that somebody way away in semi-rural Africa. That's probably the problem, Shankara.
Yeah,
If
yeah.
you were in the leafy suburbs of maybe a big city in the US or in Europe, and you said that, everybody would be jumping on it. But because they can't believe that this kind of genius can come anywhere outside of the first world, is that why they ignored it?
I think partly so, Philip, because I think we had certain regulators that were in charge of the pandemic designated. Credentials played a big part in who we believed, not the science. And science doesn't need to necessarily come from someone with credentials. Credentials mean that, yeah, you're a little more educated, but everyone's eye sees things in a different way. And I think my science background allowed me to see it differently. Philip, when I started out in my medical career, I knew I had this broad base of science, and everyone said specialize. But I knew that specialization would take away from the broadness of my understanding of physiology. And so I decided to remain in general practice. And one of the comments of my principal in my college was that he was charmed that as a general practitioner I still kept my academics in check, and at this stage in my life was still superseding my peers. But what do we call peers? An ophthalmologist sometimes forgets how to use a blood pressure meter because that's not part of what he does routinely. So I chose to remain a GP so that I could remain in touch with what family practice actually is. And I think that's what gave me the edge. And of course, the silence from all the manipulation of the narrative that was going on around the world. Not being
Excellent.
in touch with other medical professionals, listening to opinions that were unfounded in science. I was left all alone to make up my own opinion.
Excellent, excellent. So, where we are at the moment, Shankara, and I think that what has happened in the world is that we have got caught into these camps: vaccinated, unvaccinated, people in the middle, confused. Everybody's trying to get their side heard and to be right. But they seem to be missing the fact that this virus, and depending on your perspective, will determine how you describe it. But whatever this thing is, it is still circulating, it is still changing, and it is causing a lot of illness across the world. Are we getting distracted by the politics and ignoring this monster right in front of us?
Yeah, I think so, Philip. From my clinical practice every day, besides the long COVID and vaccine injuries and things like that that I got to deal with, I'm seeing constant colds and flus, which in some cases evolve into a long-term illness. And I think from the audience itself, you are hearing stories of people getting the flu that started unusually, persisted for a very long time, a few months sometimes before they actually recovered. You're hearing stories about people who suddenly had a stroke but been complaining of fatigue for a month or two prior, went through all manner of tests and found nothing wrong, and suddenly had this event happen. So in my practice, I am seeing a lot of viral infections. We're not testing for COVID, Philip, and I don't trust the tests. So I don't see the point of going and looking for COVID. But I make it a point to explain to every patient that there is this possibility of an immune dysregulation with every flu virus that you pick up. And for each one, the immune dysregulation will be rather unique, and so you got to know how you respond so that if you go into this inappropriate immune response after a viral infection, you recognize it and we can stop it timelessly. The longer you leave it unchecked, your immunity will try and cope by reconstituting itself. And that is where a massive problem lies.
So, one of the things that I look for from a clinical point of view is that there are certain symptoms that seem to be consistent with COVID. And one of them is this fatigue, this profound fatigue that people often get. And when you listen carefully to the patients, often they have no stuffy nose, headache. They always talk about a headache and the fatigue. they don't have a cough, they don't have anything else. How in the world would they then think that this is COVID? It's so nebulous.
Yes, and I think that's where Omicron has fooled us, Philip. In the first three waves, that immune response that occurred from the eighth day onwards was a very severe response. And so the patient noticed symptomatically and went to the doctor. Now, what we're having on the eighth day onwards is a very mild response, which can be ignored and will fluctuate dependent on your natural immunity. So some days you get up feeling fine, and you have a glass of milk, and if you're slightly allergic to milk, it triggers a slightly heightened immunity, and there you're feeling sick again by lunchtime, and then by the evening you're feeling better again. And so this waxing and waning of those kind of symptoms, fatigue and the rest, tend to keep patients away from going to the doctor and saying, well, let's see tomorrow. And it's only after a month or two that you realize that the fatigue is not going, that you decide to go and check it out. But the fatigue that you talk about, Philip, whereby lunchtime you feel like you need to take a nap, you just can't keep your eyes open. What I found was in the third wave, where we had the overwhelming clotting issues, the commonest symptom reported to be new from the eighth day onwards was fatigue. And so I associated the fatigue with microvascular coagulopathy because I could see people that presented with fatigue post 8 day having high D dimers. And so even now, when a patient comes in, I explain to them that even a symptom like fatigue shouldn't be taken lightly. I usually advise them that a week after the start of the viral illness, there's usually some improvement and you notice the fever and chills go away. But you want to make sure after that week that you reach a point of complete recovery. If in that second week you find that your recovery is fluctuant, stagnant, or some new symptoms, then I need to know about it immediately. A lot of patients in that period, Philip, go back to the doctor, get diagnosed with the second infection, and get repeatedly put on antibiotics. And 2 months down the line, it resolves itself, but the treatment never made a difference. And that's an immune reconstitution that's happened.
So when I think about it, because I'm always around the COVID in some way, shape, or form, and so I try and think about what is my trigger, okay? And so for me, when I think of that I've been exposed to COVID, and that happened to me relatively recently, is that I tend to get these odd uh, pains, like for instance, more tendon. So for me, it was like my left heel, the tendon was just paining, and I had to be limping around. And I thought to myself, this is going to be exposure. It's kind of like I didn't have I don't think I had a significant viremia because I had no temperature, no headaches. I wasn't particularly having fatigue, but there does seem to be an immune response that occurs even from mucosal exposure to the virus, because we do have a strong immune. Think about the other thing I get is vertigo. I can sometimes get that dizzy feeling because I've always had an element of vertigo. And then I think I've been exposed. Is it important for everybody to know what their almost characteristic symptom is?
I think, Philip, it's life saving for you to know that information because everyone's response is slightly different in both the systems affected and the severity of the symptoms itself. And of course, if it's mild, you won't recognize it. Now, all my patients that come in where I'm suspicious of a post viral kind of immune dysregulation, where they're coming in to see me a month after a flu with all these kind of symptoms, fatigue, neuropathy, strange pains, scars that healed coming back to be painful, strange headaches, vertigo, all these kind of strange symptoms that tend to be post viral infection are put down to an immune response post virus. And I treat it in the same way. And I'd say 99% of them resolve completely. Yes, there are some injuries that cannot be reversed because you left it too long. So now, when that happens, I explain to the patient in a timeline that, look, you had a flu and it triggered this response, and you took 2 months to get to see me, and that's going to cause other problems. So, in future, this is what you got to look for. Remember how you feel, and the next time you have a flu and you go down this road, be timeous in presenting back to me to change my response. So it's a different type of treatment for a viral illness, and it's a different type of treatment to suppress an inappropriate immune response and restore it. You don't do that timeously, you allow the immunity to reset itself, and that
Yeah,
can be disastrous.
this is important, I think, is that you have to recognize it early.
Yeah.
And a lot of people ignore the symptoms because they are not aware of their pattern of symptoms. And one thing is for certain is that, as I mentioned about this thing, vaccinated versus unvaccinated, I would like to caution people. The fact that you are, say, unvaccinated means that you probably are at lower risk in terms of some of the immune responses to the virus, but it doesn't mean that you're not at risk. And this one, I think, is very, very important for people to understand. We can't afford people to get casual about this virus. This is on a level that we cannot understand. And in a sense, I'm preparing. This is why I'm doing this presentation on the viral storm. I am getting my mind ready for the fact that it almost feels inevitable that we are going to have, as you would call it, a mass die out because of this virus.
Yes, and Philip, it won't be predictable because it won't be a typical viral infection that's going to kill people. It's going to be sequelae of an dysregulated immune response that went unnoticed. That's going to cause people death. I tell patients if you 95% improvement is not acceptable. It's got to be 100%. You got to be 100% back to yourself. So even the slightest symptom that makes you feel unwell, you report it. Philip, I'm a case in point. I'm unvaccinated. I have absolutely no chronic illnesses. At the age of 50, I could make a 30-year-old run around the football field and chase his tail. For 5 years with COVID, I never got the infection. The first infection I got was with Omicron, and it was a mild viral infection. But exactly to the hour on the eighth day, I lost my smell. I ignored it as a doctor, which is silly. I knew it was an immune response, but I didn't take the medication I usually would prescribe because it was only a loss of smell. So I took it mildly. The next day, I decided to take a walk down to the beach, and when I got back home, I was unconscious for 10 minutes and needed to be resuscitated. My D dimer went up, and of course, that was a coagulation event. The second time I got it, I wasn't sure whether it's COVID. I mean, it's just a flu. And of course, on the sixth day, I decided to check my D dimer and it was normal. So that gave me a false sense of security. On the eighth day, again, almost to the hour, I developed double vision for a few seconds on two episodes within a few minutes apart, and that was it. And because I had done my D dimer 2 days before, I thought, it couldn't be coagulopathy, it's probably my sinus. The next day, on the ninth day again, I had three seizures. I was hospitalized in ICU, unconscious. Every manner of blood test was done. Every single blood test came out normal. But the D dimer, which I had insisted on in a lucid period between the second and third seizure, was almost 6,000. Now, a D dimer going up from 500 on the Friday to 6,000 on the Monday and presenting as a symptom of double vision on the Sunday, that shows a sudden event. And it shows a priming in that in the first infection, it went up to 800. In the second infection, it went up to 6,000. Now, I'm unvaccinated, but I've never been to hospital in my life in any other capacity than as a doctor. It's the first time I've ended up in ICU twice in my life for just a flu. And the day before I was in ICU, I thought it was perfectly fine. So I think my case in point indicates the gravity of what we're dealing with. And on the second occasion, Philip, I got the symptoms on the eighth day. On the ninth day, I was in ICU having seizures, but they tested me for COVID and they found none. So I don't believe the tests because of the evolution of the virus and the sensitivity of the PCR. But with COVID, the one thing that tells me it was COVID is the triggering of a reaction. Now, ever since that second event, I've stayed on rivaroxaban because, I mean, the coagulation event that could happen to me is unpredictable. Just I can predict it by the eighth day, but do I wait for the eighth day to have a seizure and collapse before I decide to take some treatment? So I've stayed chronically on an anticoagulant.
And
The only
just
way
to
I know
pause
I
you
have,
there,
yeah,
I want to pause you there because that is unique to you. meaning
Yes,
that it's almost as if you have that propensity to
yes,
have some kind of clotting mechanism that needs anticoagulation. But for another person, it's very different. It's almost as
yes.
if the virus targets your weak spots. Whatever weakness you have, it targets that.
Yeah, it targets that, Philip, because there's an immune response, and our weaknesses tend to be related to our immunity. So, asthma, chronic sinusitis, all those kind of things, irritability in your bowel, all those are already existent allergic propensities, which would get aggravated by something that causes a generalized increase in your allergic propensities. And so you find those patients with atopy tend to fare worse. As well, like you say, different people respond differently. Each person's got to look at how they respond. I noticed in my family, excuse me, on the paternal side, Philip, when I treated my cousins, fathers, brothers, sons for COVID, all of them showed raised D dimers after the eighth day. And all of them showed that fatigability and things, which I immediately tested the D dimer to see clotting and put them on anticoagulation. So I knew that there's a propensity amongst the paternal side of my family to have this propensity to clot. And so with my when I got COVID, there it was the same thing. Now, because of staying on an anticoagulant on the eighth day, I do not trigger that clotting event. But by about the 10th day, I noticed the immune dysregulation because I start to get joint aches and pains. And that tells me it was a COVID infection and it triggered an inappropriate immune response. And that's when I add the steroids and antihistamines and rest to try and calm that part of things down.
So, one of the questions that people may ask, and I see it all the time, and I'm curious about your thoughts on it, is that if we are dealing with what could be a pretty serious virus that is circulating all the time, that can cause illness in anyone, what are your thoughts about bringing back masks again?
I don't think it's going to make any difference at all, Philip. It never made a difference in the first wave. Masks were never used to actually stop the spread of viruses. So if you look at cost, benefit, risk, we've seen the decrease in oxygenation when you wear a mask. We've seen the problems with childhood development when they are forced to wear masks. Uh, Facial expression is a very important thing in communication as people. So I think the side effects and risks outweigh any benefit that masking would ever bring to us. And let's be honest, Philip, we realized later on a gastrointestinal part to COVID illness. And so we've wholly disregarded a fecal-oral route of spread to that initial coronavirus. And if, of course, there is a because it was found in sewage, virus was found in sewage. So if we ignore a fecal-oral route of transmission, a mask is never going to save you in a public toilet without anyone there if there's a fecal-oral route of transmission. So I think we need to be honest and fair about what we're dealing with and the appropriate ways of actually negating it or decreasing the mortality and morbidity that would come from it. And I think that's with accepting what's happened and educating the population about timeously seeking treatment. That's the only way we're going to stop this. Otherwise, you're
Oh,
going to get immune reconstitution and the sequelae of that immune reconstitution. So every time your immunity responds, you've got to reboot it quickly before it gets set into that pattern.
so I first want to give condolences to you and to your family for the loss of your father. He was 90 years old.
91.
Um, 91. But part of what we had discussed before that we were going to talk about is to go through his case to try and understand a little bit more about the characteristics of illness that can occur. When we think about your dad at the moment, and again, I think he was unvaccinated, if I'm right, and he never had any significant problems during the early part of the COVID pandemic. What was your mic is muted at the moment? What what was his characteristic response and weakness that made you know when he had been exposed to COVID?
Philip, my dad, never got any of the first three variants, right? But what drew my attention to the neuropathic side of things, immune response causing neuropathy, because we think of an allergic immune response either dermal or respiratory or gut, but it affects neuropathy, your nerve system. It affects your circulatory system, depending on where the histamine is released and which is gets where the inflammation targets. And what brought my attention to the way my dad responded, I have a cousin of mine who developed COVID, and exactly to the day started getting very agitated and anxious on the eighth day. By the 10th day, he was now schizophrenic, slightly psychotic, had to be taken in, was hospitalized, put on a wide variety of different antipsychotics. A week later, his wife contacted me to say that they're going to confine him into a psychiatric facility because there's nothing more they can do. And when I inquired back on the timeline, I told her, I said, look, it started on the eighth day. Exactly a week before, he had the flu. And suddenly on the eighth day, he started losing his mind. So on the Wednesday, I asked her to stop all medication, all the antipsychotics, bring him to me on the Saturday. When he came to me on the Saturday, he was still confused. He didn't know who I was, and I know him from a child. He didn't know who my dad was. I drew his bloods. I put him on the standard treatment of antihistamines, Montelukast, the histamine blockers, and cosoprednisone. His blood showed all his markers to be sky high, the CRP, interleukin 6, and D dimers, which are used in COVID as an indication of an immune response. I phoned him on the Tuesday to see how he was doing, and on the Tuesday, he was completely recovered, back to his normal self. Now, I have not seen someone deteriorate psychologically that quickly and recover that quickly just with an antihistamine and steroid. So it drew my attention that there's some kind of immune response happening in the brain itself, creating this kind of problem. When it comes to my dad was a fit, healthy 89-year-old who could drive 200 kilometers to come and visit me and go back home on the same day. A fit, healthy man, loved reading his newspapers, was very in tune with all the good authors out there. And when he, about 2 years ago, had a fall and tore a tendon in his knee, required surgery. When he came out of hospital, he required a walker. So he spent some time with the cousin and his wife who nursed him. A week and a half out of hospital, he was fine. Suddenly, they contacted me one day to say he's trying to jump out of the window at night and talking to himself, and it seems like he had a stroke or something because he's completely lost his mind. So I rushed off to Peter Maritzburg, and on examining him, there was no symptoms of any clot or one-sided neuropathy or focal lesion or anything like that. He looked like he was confused. He looked like he was senile. He couldn't recognize me. He had this childish smile on his face. Uh, so I took all his blood tests, CRP, interleukin D dimer. I suspected maybe this is a COVID reaction. Uh, he insisted to go back to his own flat that day, so I had to get a caregiver to watch over him. I got back home. I started him on treatment. I got back home that Sunday night and sent off his bloods. On Monday morning, all his markers turned out to be high, but he was on the correct treatment. So I thought by Tuesday or Wednesday, I'll repeat his D dimer. On Tuesday, a cousin visited him, so I contacted him to find out how did my dad seem. Now on the Sunday, he didn't know where he was, confused. But when his vitals were normal, blood pressure, everything normal. On the Tuesday, he was perfectly back to himself. My cousin actually wanted to know why I asked, because he said I had a long conversation with him. I didn't say anything wrong. And I said, but on Sunday, he didn't know where he was. So that gave me a clue that every time my dad went into the state of confusion, it was likely COVID infection that preceded it and triggered this kind of clotting issue, because it's common in the paternal side of my family.
I want to
Uh,
pause you there, Shankara, because it was this information I've been thinking about it for a while, and coincidentally, having a patient who couldn't sleep recently, and the recommendation from the experts with regards to mental health was to try and help him sleep with some promethazine, which is antihistamine and also causes drowsiness. And initially, we saw no response, but goodness gracious, within about a week, the difference in the patient was incredible. And
Yeah.
I thought to myself, that cannot be coincidental. I mean, it could be one of these anecdotal things, but I
Yeah.
remembered the point about antihistamines to the extent now that I usually just say to someone, if you are having ongoing symptoms that are unusual, whether it's aches, pains, rash, anything at all, test with an antihistamine to see if this is mast cell related inflammation, to see, because the normal medication won't necessarily work as effectively.
Yeah. Philip, I had let's say, a baptism of fire for myself. We doctors tend not to take our own medication until we actually have to. When I got Omicron the first time, uh, when they found my D-dimer high, I was put onto a few doses of heparin. And once it stabilized, I was changed onto rivaroxaban, which was overnight in hospital. And then I came back home. But I did not take the course of prednisone steroid to reset my immunity. I did not take my antihistamines and Montelukast. I just took the blood thinner because I thought, oh, well, it was my D-dimer, and I'm not one to take a lot of pills. When I came home, Philip, I had neuropathy in an area of my spine. I've had that previously, but it was never something I needed to take a tablet for. It was just when I played a round of golf by the third hole, I realized I should have stretched before, you know? And it was so painful that for 2 weeks I struggled with it. I changed my bed, I changed my chair, I looked at everything, did stretching exercises, was on the strongest of pain medication from Tramoset to a combination of Tramoset and Voltaren and sedative at night to help me with the pain. For 2 full weeks, I struggled. And eventually, at the end of the 2 weeks, I was forced to come back to work in pain. But it's strange, Philip. In the first day at work, patients were asking me how I'm doing, and you had COVID and you were away from work, and I said I'm fine, but I got this pain in my back. And a few of them actually laughed and said, "Yeah, we had similar kinds of pains, but when you treated us for COVID, they went away." And by the Tuesday, I must have had about 6 people tell me the same thing. By Wednesday morning, I got up and thought, you're a fool. You didn't take your own medication. So I put a handful of prednisone on the table with promethazine and Montelukast and the things that I usually take. And I took just one dose of it that morning. And by lunchtime, the pain had gone. A pain that I'd suffered with for 2 weeks coming out of hospital had gone within a few hours of taking that first dose of antihistamines. So I think,
Yeah.
yeah, I've seen the profound benefits. It happened again to my dad, Philip, where suddenly after an infection, he got confused again. And again, within a day or two, he was back to his old self with steroid, antihistamine, and an anticoagulant. This third event was
Right, before you go on to the third event, Shankar, I just wanted to share something here because I think that when you had first told me about histamine, I then went looking just in case there are any medics who are watching us that don't quite believe the importance. But this is what I think happens: is that the critical central cell that gets inflamed is the monocyte. But the monocyte then releases MCP1. And this MCP1 then stimulates the mast cell to release histamine. But guess what? Histamine further stimulates the monocyte. And so then you get this loop where it then becomes ongoing, not necessarily the cytokine storm in severe COVID, but in chronic inflammation, it just won't stop because you have this circular action. And the histamine will then break one side of it and cause it to settle again.
yes. As well, Philip, because of the monocyte that's triggering the mast cell activity, there is a genetic predisposition there. So your monocyte will either, over repeated infections, either become desensitized and stop responding in that way, or become sensitized and respond worse each time. Now, in my case, I think it's been sensitized and becomes worse with each episode. So my coagulation event worsens with each exposure. So I'm becoming more and more sensitive. And I think that deals with how my monocytes respond to the virus itself. Are they learning to tolerate it? or are they becoming more and more sensitive to it with each exposure? Because I'm unvaccinated. So there's no regular exposure or constant exposure to it.
And so when your dad had the third episode and he got unwell again, was it again the same pattern of confusion?
Yes, Philip, he had been to hospital with an ear infection. I had him admitted for 4 days or 5 days of antibiotic, IV antibiotic, because it wasn't settling. He was discharged, I think, the Tuesday from the hospital. He was absolutely fine. The Sunday, I went to visit him, and he was still fine. We had a long conversation. He was going for a show, and that was the Sunday. On Tuesday, I got a call from his caregiver to say that on Monday night he was very confused. And it seems to be in the evenings that these kind of things worsen, Philip. Uh, so when she called me on Tuesday to say he was confused, on Wednesday after work, I rushed off to Durban to examine him. During the day, it wasn't that bad, but you could still see the confusion. That wasn't my dad. He was a bit almost paranoid of things around him, seeing things that weren't there, but also watching cricket and commenting on it, and so I drew his bloods, his especially his D dimer, because I was concerned about that. I put him onto rivaroxaban and some prednisone. I got home late that night and sent off his blood test the following morning. That was the Thursday. Uh, on Thursday night, somewhere in the night, he was very restless through the night. Woke up suddenly coughing, and within half an hour, became very breathless and demised. I think that was a pulmonary embolus from the way he demised. The following morning, on Friday, I got his D dimer back, and it was 2.5 times what it should have been. So he required a shot of heparin. Probably have been sensitized, like myself, through each repeated infection. So yeah, I think people need to recognize their patterns. It can be fatal. If
Yeah, this is so. Yeah, sorry to hear that, Shankar. And yes, it's difficult when I mean, you've saved so many lives in your locality and in the people around you. Did that in any way impact you with regards to your dad? Did you feel as though there was more you could do?
Philip, I think I've resolved a long time ago that my work as a doctor is a fight with our maker, and he always wins. So I'm in a tug of war with him constantly, but he knows your fate. If it was a mistake, he'll let me win. If he had intention to take you, he'll let me vacate the scene before he takes you. So I've had many resusces that were successful, only to have the patient die on the ambulance on the way to the hospital. So when it comes to that side of things, I understand that there's only so much I can do. Uh, I think a big consoling factor, Philip, my dad was a very immaculate, mannered, dressed, very strict gentleman. I think he had to be having a mischievous son like myself. But in the last 2 years of his life, uh, he was very involved in the politics of the country and what's going on around the world. And in the last 2 years of his life, I made him realize that, look, that's not a job for you. That's a job for God. We children, and we're supposed to respond as children. And I made him find that childish self. So when I went to visit him, I could see the mischief in his eyes when I entered the room. Uh, and I think that was consoling, because I think when you pass, God will come looking for his children. And the fact that I showed my dad the boy that he was long missing, it consoled me that he'd be found. And I think that was a big part of me accepting that this is what we're going to go through. Uh, yeah, the deaths are going to be close, the deaths are going to be difficult. But I'm hoping the medical fraternity would have some compassion to go back and relook at what's transpired and re educate themselves so that we're not left with just these two hands to try and save the world.
Yes, yes. And one of the things that keeps on coming up, Shankar, as I'm looking through the conversations, and it highlights this issue. A lot of people are struggling to get ivermectin. And one of the things that I'd said very early on in the pandemic is that I was interested in the mechanism because I don't believe that you should ever depend on any single drug, if
Yeah.
that makes any sense. Doesn't matter what it is, or intervention. You must always have a toolbox because there will either people who are allergic or there is supply issues. Is the public too focused on that drug at this point?
I think that they are, Philip. Uh, as much as I was one of the doctors that brought to the fore the importance of ivermectin, uh, understanding its immunomodulatory benefits and the rest. When I went down that road, Philip, I had already discovered the benefits of steroids, antihistamines, Montelukast. That was my first call. And with that understanding that there was no more of fear of the patient demising, I tested ivermectin to see if I'll get a benefit, knowing that I had a backup. But it didn't work as well as my first line of treatment. That means touching on every point with the steroid, antihistamine, the H1, H2 blockers, the leukotriene blockers, those kind of things, mast cell stabilizing agents. And what I noticed was the ivermectin was never an integral part of my protocol in treating COVID. And in that, I never had any long COVID cases. But the doctors that used ivermectin, they had an improvement in the mortality and morbidity, but they also had mortality and morbidity. And part of that morbidity was long COVID, which I'd never seen. And the first time I saw long COVID was patients that were inappropriately treated or took ivermectin only. They didn't die, but they ended up with long COVID. So I think understanding the mechanisms of how this triggers the clinical symptoms and addressing every single one of those pathways is the route to the solution. Ivermectin might address a few of those pathways. And that's the reason it'll work in some patients, it won't work in others, and it doesn't completely stop the problem. So, yes, I think it has its place in the treatment, like we're seeing with the treatment of turbo cancers and those kind of things. We understand the mechanisms around that. But when it comes to COVID itself, I think there's a lot more that we're missing if it's going to be ivermectin alone. So I don't punt any single drug. I think if there's any drug that I would have put my name to, it was a combination of promethazine and montelukast.
Now, one of the things that I was reflecting on recently, I had accidentally been involved in a conference talking about a case report. And in that case report, they had a very complex patient who was unwell, who had inflammation around the lining of the brain. The only thing that worked was steroids, but every time they stopped the steroids, the symptoms came back and they needed immune suppression going on. And when they pulled up their differential of potential causes, they didn't have in their differential COVID. And I asked the question, well, if you don't know what it is, because COVID, in my view, is now the great pretender. Anybody whose symptoms make no sense to me, I then start to look for whether or not they had COVID in the recent past. And coincidentally, the patient did have COVID in the recent past. And I was thinking, why is it that the medical fraternity has turned about even that differential with regards to COVID? What is it? Is it cognitive dissonance? Is it that they want it to go away? I just don't understand. It's like ignoring syphilis, because COVID, in my mind, is now like the syphilis. It can present as literally anything.
Yeah. I think it is a bit of cognitive dissonance. I think a lot of medical practitioners, Philip, push the vaccines, listen to the science according to what they said the science was. And now you feel that you made some mistakes. Uh, I think it's the egos of doctors as well that just don't want to. I mean, I've got a pulmonologist here in South Africa where he saw the benefit of my treatment. He understood what I was doing. And I thought, oh well, this was early in the pandemic, and I thought, well, I've got someone I can just rely on. And I had a patient after the vaccines were rolled out that I needed to see emergently. And the first question his secretary asked me was, "Is the patient vaccinated?" And I said, "No, the patient's not." And she said, "Then you won't see him." So yeah, I mean, they had very strong views. It polarized the society. It polarized the medical fraternity. And sometimes when you stand up with a loud hailer and chant your view, it's hard to retract it. So yeah, it's going to be Philip. myself, I was lucky to have had a specialist that was willing to listen to me when I had my episode in ICU. I spoke to him between two seizures and explained to do my D dimer. It's not a routine test they do, but it turned out to be the only test that indicated something that saved my life. And he was kind enough to come and sit on the bed that morning and say, "Look, if you didn't tell me to do the D dimer, you would have died." They hadn't seen that. And now he starts looking for it. He starts to understand what's going on. So you got those who put their education and their continuous development at the fore, and those that put a monetary value to their services.
I'm going to say something here that, again, if any medics are listening to, I said it recently to a younger doctor, and I said that what you are seeing now in terms of clinical presentation to you may seem to be normal because you haven't seen anything else before the pandemic. But I said that there is a very strange pattern around disease presentation pre-pandemic and post-pandemic, and it is very difficult to define. It's almost as if the stuff that you thought or the way you did things before no longer work in the same way. And it's
Yeah,
far more likely you are going to see things that make no sense.
yeah.
How does the medical fraternity deal with that if they're not willing to be re-educated?
Philip, when a patient comes and sees me, I've been a practitioner for 25 years. A lot of the time, when the patient walks in the door, I already know what's wrong. You can see a limp, you can see a swollen foot, you can see a lot of different things just by saying good morning to a patient. Now, when you get a patient with symptoms that don't fit a common pattern that you've seen in the past, that don't fit the way you'd examine a patient, doesn't make sense. A single nerve neuropathy that doesn't, those kind of out of the box things that we've never been exposed to. My first differential is post COVID immune dysregulation if they don't have an active infection. I go to that first. And if I can rule that out, I'll treat everything else. Remember, Philip, the treatment for COVID, the immune dysregulation, the treatment for long COVID, and the treatment for post vax injuries is about the same. You got to give a dose of steroid to stop that cycle. You got to use the different antihistamines, montelukast, and things to break that loop that's going on. The problem in the vaccinated is there's a constant production of spike and there's the chance of a reactivation of those symptoms. So it depends on how long you're producing it, whether we can detox you from spike. Those things come into play. But remember, that treatment that I talk about is relatively non toxic. It's not going to harm you in any way. So, a therapeutic trial of that treatment in a patient where they've been having symptoms for 2 or 3 weeks and it's not going away, why not? And I mean, when I look at it in that way, Philip, I'd say those patients that I look at in that way and say, look, this is a post viral infection, immune dysregulation, I look at where the symptoms lie more. Is it more respiratory symptoms? What kind of respiratory symptoms? Are they more allergic? Are they more likely to be related to microvascular coagulopathy, the type of cough they present with, the history, neuropathies, cognitive function, all those little things. And then, in that same modality of treatment with steroids, antihistamines, montelukast, and anticoagulation, I decide where the severity lies more. I treat all of them. But in some, I think the coagulation's worse and I'll be a bit more aggressive there. And some I'll find that the respiratory part is worse because they get bouts of slight wheezing and things like that. So I'll treat more with the antihistamines and probably add a steroid nasal spray or something like that to settle symptoms. I always look for gut inflammation as a nidus for the inflammation to or the infection to persist. So I think, yeah, it's something where you got to have that at the forefront of your mind. Otherwise, you're not going to find the symptoms. And 99% of patients that I do this with recover. But I also explain to them that you'll get well. But all it takes is a sore throat for half a day to trigger the whole process again. And so
One
you
of the
got to.
one of the problems with certainly westernized first world medicine is protocols. If it's not in a protocol, They can't do it. And so, one of the things that therefore it means is for patients, if their doctors are not open to what you are saying, because I don't know, I regularly ask people about their thoughts about whether or not long COVID symptoms are real or, post COVID. And if there is a hesitation from the clinical person, I know they don't really believe it. And if they don't really believe it, they can't treat it. They won't even consider it as an option in terms of the differential. And this is why a lot of patients are struggling because they have nowhere to go. One of the answers is going to be within the next few years. My prediction is that with the advent of AI, we are going to see medicine without borders, where what that means is that people will go wherever they want in the world to get the advice. And I suspect one of the huge limitations is to do with prescribing. You can only prescribe in the country that you are licensed to.
Yep.
But I suspect that within the next few years, we're going to have global pharmacies where it doesn't matter where someone is in the world. If you in South Africa make a prescription for them in Germany, they'll be able to get the medication, and things will shift. I guess the big challenge for patients is going to be about responsibility. If things go wrong, who is responsible if the clinician is not within the control of their local environment? Like people who would go to India to have cosmetic procedures and so on. What are
Yeah.
your thoughts with regards to how this is going to play out?
Look, Philip, I think there's two sides to that. Yes, I treat patients globally and they have problems accessing the medication. And these are medications that are reasonably harmless. So, yes, there are problems with control of the medical fraternity globally. And if there's commonality around the world, then why can't we have doctors around the world prescribe and be governed by a common set of values that protect both the medical professionals and the patients? And I think what has muddied those waters is all the collusion and bad research and punting of medications and the pharmaceutical industry's hands on approach to doctors itself. So I think what we need to do is yes, doctors need to take responsibility for their prescribing actions. So, yes, we need to have some framework, but patients also need to, in a very well informed environment, take ownership of the choices that they make and who they choose to see as their doctor. So, at the end of the day, you'll get those doctors that are clueless and will prescribe medication that does nothing. You have those doctors who will have better results and will attract more clientele in that way. Medicine will be globalized. And so, yeah, we're going to have the regulatory frameworks looked at. I think the medical associations have been captured, and as much as they have a general commonality in their framework, there's no global commonality that allows doctors to treat across the globe. And that's what we need to set in place.
Yeah, and so when we think about what's happening in, say, for instance, the United States, and for those people who don't realize, is the US generally sets the pace and the direction for health practice across the world. This is why when Biden instituted vaccine mandates in the US, the rest of the world followed. When the US says that a certain medication doesn't work, the rest of the world follows. So we have a situation now in the US with RFK, who is really smashing through everything. I mean, I am surprised at how much he is trying to disrupt the apple cart at the moment. Is this going too far, or is this the kind of action that is needed to actually bring the world to a better place for health in the future?
I think it can never go too far, Philip. I think it's gone too far already before we started to dismantle it. And of course, we built a system that doesn't work. It's full of collusion, it's full of corruption, it's full of bribery, it's full of perverse incentives. So, do we try and fix it, or do we destroy it with the truth and rebuild a new system that's actually based on patient welfare? And I think that's where we're at. We need a complete destruction of the structural integrity of what healthcare has been thought to be, and a complete restructuring of what health services actually mean, taking out the egos that are there, taking out the allopathic superiority, and making sure that there's collaboration in general health. I think that's what RFK is trying to do. But of course, there's going to be big pushback from those with the money. But it's something we have to do if we got the patient's interests at heart. So I'm glad that he's being that disruptive. At the end of the day, there are people who swear by the science that was never verified. We know that the pharmaceutical industries brought out certain articles to justify what they wanted to do, and people believed in that, Philip. So it's going to be hard to break those preset notions. And I guess the only way to do it was with shock. Put the truth out there, the truth and the whole truth and nothing but the truth. And no matter how it shocks people, at least the world gets to see what's there. Those that awaken will take the necessary steps to protect themselves. Those that refuse to awaken for whatever reason will remain in the doldrums and have to face the consequences of that. I guess at the end of the day, Philip, not everyone makes the ark.
Yes, Noah's Ark. Yes, and so I used that analogy recently. It does feel like we're in a situation where we need an ark at the moment. And so it raises this huge challenge as I look forward to, when I say look forward, look to the future. I want you to challenge or agree with these thoughts. One, I think that certainly within 5 years, and I think it could be much faster within 2 or 3 years, AI is going to completely disrupt medicine in a
Yeah.
way that people just can't imagine how quickly it's going to change. That's one part of it. It will mean, therefore, that the clinicians who are operating outside of a protocol, because if there is one thing AI is good at, it's protocols. And so if you are practicing protocol based medicine, where essentially it is just standard one step, two step, AI is going to completely demolish that.
Yes.
And I believe, as well as I said, there is going to be no borders in medicine within the next few years because it will be impossible. So, if someone wanted to see a doctor or speak to a doctor in Pakistan, or Tunisia or wherever, they will. And therefore, there will be much less control of what patients do and how patients select to be managed by their health. What are your thoughts?
I think, Philip, you're absolutely right. AI will negate some of the automated functions that doctors do, like following protocols and the rest. But I think AI will also have benefit in that it can it can plot an individual's thought pattern and responses, and allow like myself, if I used AI, I'll be able to help thousands more the patients than I can at the moment using AI technology. So AI is going to be an integral part of our existence, whether we like it or not. And I think we need to embrace it and find positive ways to use it. We know that it's being brought out for a negative connotation, but yeah, we got to find a way to co-opt it and use benefit. So it's going to be an integral part of medicine. It's going to make a lot of medicine obsolete, but it will not affect the critical thinkers and those that see patients as individuals and individualize their diagnosis and treatment of patients. That AI won't be able to take over. And so there's going to be a large contingent of doctors that will become obsolete.
Yes, yes. So this is a challenging time for everyone. And as I said, as we close out now, Dr. Chetty, I think that the most important point that I want to get across to people is that I believe we are in the calm of the storm. We had the first set of winds of the hurricane in 2020, 2021 up till Delta. The Omicron wave was somewhat of a calm of the storm. The problem is that if you have ever experienced a hurricane, is that right after the storm, meaning that right after the eye passes over, the winds pick up dramatically, literally within seconds. They are at 150 miles an hour. And that's what does most of the damage in a hurricane. And so my feeling is that we are right on the brink of some kind of change, because what's happening now with this circulation of virus is, in my view, not sustainable. It is putting too much at risk, population wise, animal wise. Everything is being put at risk. Somehow, there has to be a recalibration. What will that look like, Shankara?
Philip, this is a topic that came up many years ago with the start of GMO in the 80s, where we modified crops for better yield, and we looked at down the line what would the consequences of that be. We've seen that we've seen what's happened to food supply around the world. We've seen the difference between GMO produced wheat and non GMO produced wheat. We're starting to see all these spiraling effects. Now, when you do that with that's just with plants. When you start to do that with animal genetics, then it spreads between species, and there's a commonality between it. There's migratory patterns that involve the spread of viruses. There's all these things that come into play. So, natural selection is what's going to be the determinant of where this ends, invariably. We can only prolong your life for so long in the event that you have this kind of thing happen to you. So, yes, we can do our best to help those that have the reaction prevent a reconstitution. That'll give them quality of life, hopefully, not shorten their lives. Those that don't will sit with all the problems. We've seen that COVID has decreased, not COVID, but the vaccines have decreased the birth rates around the world and have increased the death rates. That's going to narrow that gap. How far it narrows that depends on the fittest in the population who will tolerate this the best and survive it. Uh, Surviving it does not necessarily mean surviving it unscathed. So we might find that there's a portion of the population that were unaffected or unaffected in their longevity, but have some form of deficits. I'm concerned that Omicron is neurotropic. I'm also concerned with the number of patients around me suddenly reporting memory problems, short term memory loss, absent mindedness, those little symptoms that were never there before, but they're becoming more and more noticeable that patients are actually reporting it. So yeah, there's far more to come. My concern is that there was always this thought of another pandemic. We saw the avian flu virus. We saw SARS-CoV-1 and then SARS-CoV-2. It got improved along the way. We saw the first bird flu infection that did nothing, but we've got another one seeming on the horizon. We've culled all the chickens. We've not allowed to eat eggs, so they started that flame of fear. Now I see an article today where they want to cull 400 ostriches that have gotten over the bird flu and got immunity from it. Now, bird viruses generally don't infect human beings, and if they do, there's a very small chance they would infect and a very small chance of mortality. But they've been playing around with this virus, and I've seen articles about it being manipulated to infect mice, and those are mammals. So now you've taken an avian virus and manipulated it to infect mammals that makes it prone to infect human beings. We've seen an event take place globally, like prior to COVID, that discussed what the interventions would be in case of an avian flu pandemic. Is that in the pipeline? Is that the reason my case got deferred so that we can't prove that this was all man made? So I'd say we need to err on the side of caution. There's more to come. So, yeah, as much as COVID is still circulating, Philip, I think it might not be a big enough distraction for what's coming. When you look at Trump and the Epstein files and what's going on in Israel and the Ukraine, they need a healthy distraction. And Philip, if you take context, I think that the COVID vaccines have killed far more people globally than the Ukraine war and Gaza combined.
Great. Yes, you'd have to end on a controversial note. Yes, Shankara, as usual, much appreciated. And I did take note of what you said, especially at the end. So thank you very much for being with us. And we look forward, whether or not it's at a conference or another talk like this, we look forward to hearing from you. And please be noted, there will be a Shankara Chetty website where you will be able to get in contact with him and his team about international consultations. I think that that's the future, and we look forward to the AI version of you as well.
I do too, Philip. As a geneticist, I was resisting being cloned like Dolly the sheep, but AI makes it a more worthy proposition.
Okay, then, Shankara, just stay with me for the outro. Thank you all very much. Until we talk again, have a good evening.